Damage control orthopedics aim to achieve hemodynamic stability with minimal orthopedic intervention. Rapid emergency surgery to save life, limb, while avoiding time-consuming traumatic reconstructive surgery. Involves staging definitive management to avoid adding second hit to the patient. Patient at increased risk of perioperative complications such as ARDS and multi-system organ failure during acute period after polytrauma. When to perform definitive surgery. Clinically, patient is normothermic. He has a good urine output. He has a good mean arterial pressure of more than 60 and he has a heart rate of less than 100. Labs, he has a lactate which is normal. His platelets are normal. His INR is normal and his interleukin 6 is normal. So if the patient can perform definite surgery if heart rate is less than 100, mean arterial pressure is more than 60, lactate is less than 2.5 millimole per liter. Lactate is the most sensitive indicator for adequate perfusion, indicative of anaerobic metabolism. Patient should have no coagulopathy, platelets count should be more than 95,000 and INR should be less than 0.5. Inflammation causes platelet dysfunction and accelerate fibrinolysis. Patient should be normothermic and urine output should be 1 milligram per kilogram per hour. Normal interleukin 6 base deficit. Normal is equal to -2 to +2. Indicative of metabolic acidosis. Principle of surgery. X-fix of long bone fractures. Irrigation and debridement of open fractures. First aid produces inflammatory response and raises interleukin 6 and interleukin 10. Manage coagulopathy and metabolic derangements, and hypotensive resuscitation should be given. Early total care, definitive fixation of all the bones within 24 hours once patient is physiologically stable. Consider simultaneous surgeries with multiple surgeons to reduce the operative time. Long bone restored length, alignment, and rotation. Evidence of early total care, damage control orthopedics, and early appropriate care. Pape et al. Showed damage control orthopedic as adequate alternative for patients with high risk of traumatic complications such as ARDS and MODS. Pape et al. 2005 differentiated trauma patients into 4 categories: stable, borderline, unstable, and in extremis. For them, stable will go for early total care. Unstable patients should go for damage control orthopedics. Patient in extremis should go to ICU. And for borderline patients, it should be early total care or damage control orthopedics depending on the resuscitative status.